So my topic for the next 15-20 minutes will be to talk about shoulder pain, and specifically pain related to shoulder arthritis. And shoulder arthritis is probably not as frequent a problem as we see in the hip or the knee, since it's not a weight-bearing joint. But on the other hand, it is still a significant problem. And the rate of joint replacements for shoulders is increasing much more significantly than for hips or knees, probably because of better training of orthopedic surgeons who are more familiar with shoulder replacement surgery. So I'm going to talk a little bit, I'll try not to repeat what Paul said about anatomy, and then we'll talk about the different types of shoulder replacements that we have available, how we do it, though there'll be no blood and guts, what can go wrong, and we'll leave some time for questions, and we have a couple of patients here who can talk to you about their experience with different shoulder replacement surgery. So Paul already discussed the anatomy a little bit, but with regard to arthritis, the issue really is at the joint itself. And the joint is composed of the humeral head, which is the top of the arm, and the socket, which is called the glenoid, which is actually part of your shoulder blade. And normally there's a nice layer of cartilage, which is sort of the buffer between the two bones, that allows for gliding movement and lubrication. So the muscles are important in understanding how the shoulder works. And on the very outside of your shoulder, the cap really of your shoulder is the deltoid muscle. And in the front of your shoulder is the pectoralis major muscle. And there is an interval or a space between these two muscles, and that space is one that we take advantage of when we do shoulder surgery. We can actually get down to the shoulder joint by going through this little space or interval that we call it. This is kind of slightly grotesque, but hope you're okay with it. This is a right shoulder, and these are the rotator cuff muscles that, that Dr. Seth was talking to you about. And the front of your shoulder blade, there's a large muscle called the subscapularis, which is one of the rotator cuff muscles. And looking from the back of a right shoulder, on the top is the supraspinatus muscle, and then there's the infraspinatus muscle, and then the teres minor. And those four muscles all join on the top of your arm to form the rotator cuff, as you heard earlier. So with regard to shoulder arthritis, we will often, get x-rays in the office. And in the x-ray, normally you can see between the humeral head and glenoid there's a space, and that space is preserved by cartilage. But when people develop arthritis, as you can see here, the space starts to narrow significantly, and these little bone spurs start to form. And the space is narrowing really because the cartilage is being lost. And why people lose cartilage in arthritis is not clearly known. But when we look into shoulder joints that have arthritis, the tissue is sort of loose and just sort of falling off of the bone. Why it happens, we don't really know. Symptoms of arthritis would be pretty much what you think. Basically, it hurts. It hurts when you move it. It hurts when you lie down. It hurts when you sit, and it can be quite debilitating. The pictures on this side show you what normal cartilage would look like on the top of the arm. This is a humeral head with normal cartilage. And over here is an intraoperative picture of a humeral head that has arthritis. And you can see what's happened, that it's now rough, irregular, it's pitted, and this is inflamed and irritated, and is a quite unhappy shoulder, and this person was undergoing a shoulder replacement. On examination, you can often see atrophy of the muscles because people can't use their shoulders normally, so the muscles will atrophy. There is sometimes swelling. There's usually pain if you push on the joint. There's often catching or snapping, which is we call crepitus, which is these abnormal surfaces rubbing against each other. And typically there is some limited range of motion that's painful. So how do we treat it? We treat it with multi-modalities. We will often use a combination of rest. Physical therapy I'm often asked about for arthritis. It's not terribly effective because, as you can imagine, you take an arthritic joint which has abnormal surfaces and start pushing them harder and harder, it often makes the joint feel worse. It can be helpful, however, if someone has developed significant loss of motion. Sometimes we can improve the range of motion with physical therapy. Anti-inflammatory medications, injections, these are all what I consider to be temporizing measures in treating arthritis, and certainly it makes sense to always go through these measures, and many people can survive for years and years with a combination of medication, occasional injections, and some stretching exercises. If it gets severe enough, though, then we move on to surgery. And what do we do in surgery? There are a couple of different options. If someone has milder arthritis, we can do arthroscopic surgery, where essentially we clean up or debride the arthritis. Chondroplasty is another word for just smoothing the joint surfaces. The loose pieces we can take out, and if the joint is stiff and tight, we can do something called a capsular release, which improves range of motion. If you improve range of motion, people feel dramatically better. As the arthritis advances, we move into a little bit more aggressive type surgeries, and one is called a hemiarthroplasty, which is a half of a joint replacement. And then there's the total replacement surgery, which there's two types, which we're going to talk about, the standard shoulder replacement and the reverse shoulder replacement. Hemiarthroplasty we will do in younger patients. We'll do it in those patients because often the socket is still in reasonably good shape. Or there are some patients who have such bad sockets that they don't have enough bone to support a plastic socket, so they would have a hemiarthroplasty. There are some surgeons who aren't really comfortable doing total shoulder replacement, so they will use hemiarthroplasty. And prior to the reverse replacement, we would do a hemiarthroplasty in patients who had arthritis and badly torn rotator cuffs, because that was our only option. Total shoulder replacement was really pioneered by a doctor named Charles Neer, and Dr. Neer was a Columbia Presbyterian for many years, and I was fortunate enough to do my shoulder fellowship with him as one of his last fellows before he retired. And in the mid-70s, he promoted shoulder replacement with the concept of trying to preserve as normal anatomy as possible, minimal bone removal, no mechanical stops, meaning it's an unconstrained joint, just like the one you're born with. And really, he wanted to provide a fulcrum for the muscles to be rehabilitated. And he always emphasized how important the muscles are, and it's absolutely true that a good joint replacement with poor muscles will not work. So, why do we do shoulder replacement? The most common indication is osteoarthritis, which is the most common type of arthritis that we see. Rheumatoid arthritis is an inflammatory type of arthritis. It's more of a systemic illness or disease. And we do shoulder replacements for that as well. People who dislocate their shoulders many times over can develop arthritis, which we call arthritis of dislocations. Or, as Dr. Seth showed you earlier, post-traumatic arthritis, if somebody fractures their shoulder and disrupts the normal congruity of the joint, that can often lead to arthritis. Someone with chronic rotator cuff tear, which we call cuff tear arthropathy, eventually the joint can degenerate and you develop arthritis with a chronic rotator cuff tear. Now, Dr. Seth is an excellent surgeon, I can vouch for that, but when he tried to show me how to ski the moguls, he wasn't quite as successful. So here's how we do a shoulder replacement in 7 easy steps. And it's really not too difficult. We remove the arthritic part of the arthritic ball. We create a channel in the bone. We create a channel in the socket. We put a metal stem that goes into the bone that is sized for everybody's individual anatomy. We put a plastic socket that gets glued into the scapula, which is the glenoid. We then have different size head components that can fit on the stem. And there you have a standard shoulder replacement. And it's essentially a resurfacing of the joint. It's a metal ball, plastic socket. And people think of total joint replacement as some kind of barbaric procedure where you're chopping out someone's entire joint. You're really not. You're resurfacing the joint. The key about a standard shoulder replacement is that it requires a rotator cuff to be intact and working, because it's the rotator cuff that lifts your arm, and it will not work. This operation will not work without a rotator cuff. And here you can see a preoperative x-ray on the top. Joint space is narrowed, there's spurs, and here is after replacement. Stem goes inside the bone, metal ball, And the plastic socket you really can't see very well, except there's a little metal marker in the middle of the socket. So this is a little animation of a standard shoulder replacement. And you can see it's basically new surfaces. And the other thing you can see in the animation is that about 2/3 of the motion in your shoulder comes from the ball and socket, and the other third comes from your shoulder blade moving against your back. So when people go to physical therapy, the therapists make a big deal out of this, and it's very important for shoulder range of motion to have your shoulder blade working properly. Paul talked about rotator cuff tear, so I'm not going to spend too much time on it. This is an MRI in the middle showing a tendon, which is this black line here, which is detached from the bone. The white is fluid that isn't normally there, and that is what a torn rotator cuff looks like on MRI. And this is an arthroscopic picture of a small rotator cuff tear. Now, if you have a large rotator cuff tear, meaning you've torn 3 or 4 of your rotator cuff tendons, what happens? Well, your deltoid muscle, which attaches to the upper part of your arm down here, the deltoid pulls up on your arm and you try and elevate it, but because there's no rotator cuff sort of pushing the head down against the socket, the ball starts to ride high. And it rides high and higher and eventually starts wearing into the bones on the very top of your shoulder called the acromion and the clavicle. So there's a superior migration of the head. The joint is now unstable, and people cannot raise their arm with this condition. And it's quite disabling, as you can imagine. So in the past, what did we do? Well, we would do a hemiarthroplasty, and the hemiarthroplasty is as seen here, where there's a metal ball, stem inside the bone, no socket has been put in, but you see what happens is the ball rides high. This has reduced some of the pain, but the function is still not very good. And Dr. Neer described this as a limited goals prosthesis because he knew, and he would tell patients ahead of time, that this is limited goals. It will not allow you to raise your arm, but it would help with pain. If you try and put a total shoulder replacement in a patient without a rotator cuff, what happens? Well, that ball that's riding high will rub or bang into the top of the socket and loosen it, and that's been called a rocking horse glenoid. So total shoulder replacement without rotator cuff, the standard total shoulder replacement, doesn't work. So that was all we had available up until 2004 when the FDA approved the use of the reverse prosthesis in this country. And this is a prosthesis that was pioneered by a French surgeon named Paul Gramont, and he started this really in the mid-'80s, and it's been used in Europe since the late 80s, but not in this country until 7 years ago. And this is a new concept, and this is a concept that allows a shoulder replacement to be performed in a patient without a rotator cuff, and it allows them to raise their arm because the deltoid takes over, and I'll show you how that works. So some of this may get a little technical, but basically the center of rotation of the joint, which is normally here, has been brought lower and medial to where it normally was, and the ball, which is normally on the top of the arm, has now been placed on the socket. So there's a ball here and now a socket here. So that is the reverse of the normal anatomy. But this, by doing so, we've now created a fulcrum here so that the deltoid, when it pulls from here, can now elevate the arm because of a fulcrum. If you just put the ball like we showed with the hemiarthroplasty and the deltoid pulls, it would just ride up into this bone. So this was the concept behind reverse shoulder replacement. And here, on this side, you can see what the reverse replacement looks like, where the ball has been placed higher up against the socket, and we create a socket where the ball was, as opposed to the standard shoulder replacement where the ball and socket are in their normal positions. So this is just a similar animation. You can see that if it moves, similar to the other shoulder replacement, but a completely different configuration. And so here they are side by side, the standard shoulder replacement and the reverse shoulder replacement. So This is a patient, the first patient that I did a reverse shoulder replacement on. This was in 2006. And he came to see me with multiple incisions on his left shoulder. He had had several rotator cuff repairs performed elsewhere that had not healed. And that's the extent that he could lift his arm in the forward direction. And that was how far he could lift his arm laterally, or what we call abduction. And he was quite unhappy. This was his x-ray, and you can see he has these metal screws from his previous repair. The ball is riding high relative to the socket. The space is narrow because he's developing some arthritis. And here he is. That x-ray was February. Here he is 3 months later in May. This is his postoperative x-ray. And this is his ability to lift his arm 3 months after the surgery. And he looks a little happier in this picture. Another patient, similar problem. No rotator cuff, ball is riding high, narrowed space here, reverse shoulder replacement, and quite happy. So, the reverse replacement has been a great addition to our armamentarium for patients with arthritis and severely torn rotator cuffs. Generally speaking, the reverse replacement has a higher complication rate, primarily because it is often done in revision settings for people who have had multiple failed surgeries, and so that will lead to sometimes higher complications. What are the complications? And the list can be quite long, but the things that we see that can happen: infection, the joint can come out of place, there can be problems with the mechanics, the screws, but we've looked at our series at ONS, and fortunately our complication rate is only 3%, which is quite low compared to the national average, which is actually 20 to 40% for reverse shoulder replacement. So here's an example of a patient of mine, 2001. He had a hemiarthroplasty for his arthritis and torn rotator cuff because that's all we had available. 2008, he had a reverse. And of course now he wants to know why I didn't do the reverse. Well, we would have to go to Europe in 2001. So thanks for your time.